My name is Kristie Lancaster, and I am the chair of the EPI Lifestyle Scientific Sessions for 2021. This year, our opening keynote was about structural racism, social justice, and health equity. And here with me today are the speakers, Dr. Olajide Williams and Dr. LaPrincess Brewer. This was especially important for us this year with the climate over the past year. And I'm going to start with Dr. Williams. Can you please share with us the take-home messages from your talk?
Well, I think my hope was one, to really sensitize the audience to the pervasiveness of structural racism in this country, the ubiquitous nature of structural racism across every sector, and two, to really unpack some of the neuroscience as it relates to conditioning, around bias that really results in often implicit biases, but also explicit biases, and just understanding that these biases are deeply wired in our cerebral infrastructure, and unmitigating them or unwiring them is going to take a really huge societal as well as individual effort. Three, I thought it was really important to really show how this bias creeps into all forms of racism, and including structural racism, which is the codification of racism within our society structures, and how this structural racism marginalizes communities and creates adverse social determinants of health that directly impact not only the mental health of individuals who are on the receiving end, but also the physical health. We are the American Heart Association, and cardiovascular disease is one of the physiological consequences of structural racism. And for me, it was important to really show that journey from racism to cardiovascular disease, and the role that we play, not only as individuals, but as a society, in propagating a racial bias.
Dr. Brewer, what would you say is the take-home message from your talk?
So again, I'm truly honored to have been invited, and I am truly impressed that the AHA is recognizing the importance of community engagement in order to achieve health equity and to fight many of the structural inequities that are out there. And I felt that my keynote dovetailed quite nicely with Dr. Williams' talk, in that we're showing how meeting people where they are in the community can help to build a bridge between these marginalized communities, to help them achieve their best health or cardiovascular health equity. So my goal with my talk was really to take the viewers and listeners on a journey of how community engaged research through the form of community-based participatory research, which falls under the umbrella of community engaged research, and how CBPR can be used by partnering with communities to, one, understand what their priorities are first before going in with your own agenda, and then taking that priority and building an intervention or solution with their input. So you have to have their lived experiences. What is it that they feel could help them to reach their best selves and lives? And then it's so beautiful how you can come together as the academic partner with your expertise and merge that with the expertise of the communities to develop an intervention. And our project, FAITH, which stands for, it's an acronym, stands for Fostering African American Improvement in Total Health, merged both insights from the academic and community teams to come up with an intervention to promote cardiovascular health. So it really shows that partnering with communities can be rewarding and it can truly impact cardiovascular health.
So for both of you, and I guess we'll start with Dr. Williams again, how do you think that researchers and clinicians or people can put this into, I guess, future research and practice?
I think one of the first things that we need to do, there's a tendency, Kristie, to look at a group of people who are poor or marginalized and ask, what is wrong with them? Why can't they pull themselves up by the bootstraps? But the question we should ask is not what is wrong with them, but what happened to them, and why don't they have any bootstraps? This is the fundamental principle governing trauma-informed care, and I'm a big proponent of trauma-informed care, not just for communities that have been traumatized, but assuming that every patient that we encounter has a history of trauma and applying those same trauma-informed care principles to every patient encounter. And I also think that it's also critically important for us to really expand the research that we do into the domain of social determinants of health, trying to understand the mechanisms behind interventions that actually reduce or buffer the impact of social determinants of health on individual lives. And so I think that we are beginning to slowly see more research in this area around structural racism and its effect on social determinants and social determinants and its effect on the individual. But I do think that we need to really focus not so much on understanding and dissecting the problem from an epidemiological perspective, but finding solutions and interventions and applying those interventions and solutions and understanding the mechanisms that actually lead to them working. That way we can take those and apply them and scale them to interventions across this country so that we can begin to really intervene on the issue that's informed by research that's really looking for solutions. One thing I loved about Dr. Brewer's work is that she's focused on the solutions. She's focused on CBPR as as one solution to this issue. And I think that we definitely need a broad suite of interventions that target solutions and less so the analysis and the paralysis of analysis that we've found ourselves in over the last few decades when it comes to understanding racial disparities. So it's time for research to pivot and have a much more intervention solution orientation.
And Dr. Brewer, odds are most of our viewers are not doing CBPR and probably not community work. We've got epidemiologists and clinicians and others. And so what would you suggest? How can they take some of your information and use it in their work?
Again, I want to emphasize that community-based participatory research is not, community-placed or community-based. I'm just going into the community, I'm going to ask them some questions, and then I'm just going to go and make my own intervention. No, it's about a long-term relationship, building trust, a co-learning bi-directional relationship where you are both learning from each other to jointly come up with a solution. So that's the take-home point truly that I want people to know. So in order for researchers or public health practitioners, again, you must listen to their needs and really understand where they're coming from. So as Dr. Williams mentioned, what have they experienced that, or what's around them, what's their sociocultural context that's leading to some of their behaviors or just their lack of ability to live healthier. So with a better understanding of those things, you can then develop the solution. So before going into kind of outlining what your intervention is, you really need to understand the community's lived experience and then take that in tandem with the literature to develop these interventions. And I also want to emphasize, as Dr. Williams mentioned, you have to have interventions grounded in a behavioral theory or conceptual framework. Why is it working? You can't just come up with something and just think that it worked. You really have to come up with a framework and say, this is how I think this can improve their outcomes. So oftentimes I'm asked by community members, why does this have to be research? Why can't this be a form of altruism from the academic institution or medical center? And I always respond with, you know what, you're right. However, we want to make sure that there's a service component, but we also want to make sure that this works. So we don't want to waste your time by coming up with an intervention that is not grounded in theory or behavioral frameworks, so that we can actually know how the intervention can improve outcomes. So we just want to make sure that the community members know that we want to see if this works for your community. That's why it's research. Otherwise, we're blindly coming up with interventions that are not impacting the long-term population health of these communities. And it's also a disservice, if you will, by not knowing how something works and then giving it back to the community and showing them what you found and how this has impacted their community. And that's the basis of community-based participatory research. It's a long-term partnership in which all partners, both the academic and the community partners, are involved throughout the entire research process, from the conception of the research question all the way to dissemination of the findings and ensuring that it's actually having an impact on the community. So this is why we use research in what we do.
Well, thank you both so much for your enlightening and exciting talks today.